Now, in this section, let's talk about two other important causes of granulomas of the nose, and they are also bacterial causes. In this section, we will talk about rhinoscleroma and syphilis, and what are the causes of rhinoscleroma, what are the clinical features and diagnosis of rhinoscleroma, and also we will talk about the syphilis and how it manifests and how it is diagnosed and managed. So first, the rhinoscleroma. This is the picture of rhinoscleroma. If you can see, it's a really, really bad condition in which there is granuloma formation, and it's called the rhinoscleroma. A chronic granulomatous disease caused by gram-negative bacillus called Klebsiella rhinoscleromatis or fish bacillus. So it's again bacterial infection, chronic granulomatous disease caused by the gram-negative bacillus, which is known as Klebsiella rhinoscleromatis. This is the picture of rhinoscleroma and how badly it affects the nose and the lips and the upper part. It's endemic, and in India it is more common in the northern part. It's endemic in origin. Some certain population in certain regions are always affected by this rhinoscleroma. Pathology is starts in the nose. So rhinoscleroma starts in the nose, and then it extends to nasopharynx, oropharynx, larynx, trachea, and bronchi. So it begins in the nose, that it involves the other parts of the respiratory system and reaches almost to the bronchi and trachea. Mode of infection is unknown. It's not very clear how it spreads. Both sexes of any age can be affected. So it affects both male and female equally, and all age groups are affected by rhinoscleroma. It is a chronic granulomatous disease, badly affects the patient, begins in the nose, then spread to nasopharynx, oropharynx, trachea, and bronchi. This is the histological picture of the rhinoscleroma. The clinical features of rhinoscleroma is atrophic stage. It resembles like atrophic rhinitis, in which there is atrophy. A foul-smelling, purulent nasal discharge is present in this stage. There is crusting also in this stage. This is the picture. You can see the granuloma formation and causing obstruction, but this is the atrophic stage in which there is atrophic rhinitis. Then we have granulomatous stage. Granulomatous nodules are produced. This is the granulomatous stage. You can see the granulomas present. Subdermal infiltration. And also there is painless and non-ulcerative nodules present. So we have atrophic stage, then we have granulomatous stage in which the granulomas are produced, and these are painless and non-ulcerative. Ulceration do not occur in these nodules. Then we have cicatricial stage, in which there is stenosis. Now the narrowing of the nares takes place, or the narrowing of the nostrils occur in this stage. There is distortion of upper lip. The upper lip is distorted and disfigured. Adhesions in the nose, nasopharynx, and oropharynx occur, and all these obstructions and blockages ultimately cause nasal obstructions that can be a very, very big complication of these granulomas. There is also subglottic stenosis. The diagnosis is infiltration of plasma cells, lymphocytes, eosinophils, Mikulicz cells, and Russell bodies in biopsy. These two cells are the diagnostic cells of this condition. You can see these foam-shaped plasma cells, and then we have the Russell cells also. Mikulicz cells and Russell's bodies are diagnostic features. Mikulicz cells are large foam cells. These are large foam cells, and Russell bodies are homogeneous eosinophilic bodies. So in this histological picture or slide, you can very clearly see these two types of cells, and they are diagnostic of this condition: Russell's and bodies and Mikulicz cells, due to accumulation of immunoglobulins. Causative organisms can be cultured in this condition. Treatment is streptomycin 1 gram per day and tetracycline 2 grams per day in combination. Minimum dosage period is 4 to 6 weeks or 1 month. Then we have consecutive negative culture from biopsy, then treatment stop. So treatment should be given for 4 to 6 weeks or 1 month, and if the cultures become negative, then the treatment should be stopped. Combination sometimes can be used with steroids, and sometimes the surgical treatment can also be tried. So all these are the different treatment options for rhinoscleroma. Next, syphilis. Nasal syphilis can be acquired or it can be congenital. So it can be acquired or it can be present at birth or it's congenital. Acquired type of syphilis is primary, which is rare, manifest as chancre of nasal vestibule. Diagnosis by manifest as simple rhinitis. The secondary, now we are talking about secondary acquired syphilis. Primary is rare. Secondary is rarely recognized, manifest as simple rhinitis, diagnosed by presence of mucus petechiae, mucus patches in pharynx, rash, fever, and lymphadenitis. So syphilis can be acquired or congenital. Acquired syphilis of nose can be primary or secondary. Primary is rare. Usually it is manifested by the chancre. Secondary syphilis it manifests as rhinitis, and it is diagnosed by presence of patches in the pharynx. There is fever and also lymphadenitis. Then the tertiary syphilis is, in the tertiary syphilis, nose is involved, and this condition is manifested as gumma formation, destruction of septum, perforation of nasal discharge, and saddle nose deformity. So primary syphilis, secondary syphilis, tertiary syphilis, as the stages progress, the condition becomes worse and worse. And then in the tertiary syphilis, there is gumma formation, perforation of the septum, there is discharge, and there is saddle nose deformity. Next, the congenital nasal syphilis can be early. Early syphilis congenital occur in the first 3 months of life, manifest as snuffles linked with fissuring and excoriation. Late congenital manifest around puberty. Like tertiary stage of acquired syphilis, there are gummatous lesion, corneal opacities, deafness, and Hutchinson teeth are present. So congenital syphilis can be early in the first 3 months or can be late at the time of puberty. Late syphilis is usually is characterized by gummatous lesion and also by corneal opacities, deafness, and Hutchinson's teeth. Diagnosis and treatment of the syphilis diagnosis is by serological test VDRL, which is venereal disease research lab testing. Tissue biopsy, Treponema pallidum is the causative agent of the syphilis, so biopsy is done to look for Treponema pallidum. Treatment is drugs of choice are benzathine, penicillin. Dosage regime for syphilis is 2.4 million units intramuscularly every week for 3 weeks with total dose of 7.2 million units. Benzathine penicillin is the drug of choice. Surgery is done for removal of bony and cartilaginous sequestra. And then cosmetic deformity, if there is any deformity like saddle nose, that can be corrected cosmetically. Correction of any deformity. The complications include vestibular stenosis, perforation of septum and hard palate, secondary atrophic rhinitis, and then we have saddle nose deformity. These are all the complications of syphilis. You can see the bad rash of syphilis and all these skin lesions as a result of syphilis. So that was all about rhinoscleroma and syphilis. Thank you for watching sqadia.com.